My presentation is going to be titled Lumbar Fusion, Laminectomy, and Patellar Tendon Repair Post-Motor Vehicle Collision. The purpose of this case study is to understand the implications of multiple surgeries on rehabilitation and to evaluate the effect of psychosocial aspects on return to work. So my patient was a 46-year-old male who was involved in a car accident on July 1st, resulting in an L4 burst fracture. Within the following days, he underwent an L2 through L5 fusion, L3 to L4 laminectomy, and a patellar tendon repair on his left knee. Here are some of the MRI findings shortly after his accident. He had a severe three-column fracture deformity of ligamentous injury involving anterior and posterior longitudinal ligaments, as well as the ligamentum flavum. A severe three-column fracture meaning the front, middle, and back of the vertebrae were involved in the fracture. He also had retropulse fracture fragments with near complete effacement of the subarachnoid space concerning impingement for the cauda equina, which is why the laminectomy was indicated. So now we're going to go over some background information on the procedures they did on his lumbar spine. A lumbar fusion, what they do is they done to eliminate motion between the vertebrae. It's most commonly done due to spinal stenosis, pain due to degenerative disc disease, or in this case, the fracture. A lumbar laminectomy, what they do is they remove the lamina to create space, usually to relieve the pressure on the spinal canal or nerves, and it was done to relieve the fracture fragments that were possible impingement of the cauda equina. So overall, as a 46-year-old male who was in a motor vehicle collision July 1st, he had no previous surgeries, and he worked as a post office worker in the back, picking up packages and talking to them whether there could be somebody else there or get into tight spaces, but he was required to stand for longer than 4 hours at the time, and they required him to be able to lift over 70 pounds overhead. So the way I set up my presentation is in 3 different stages. So you can see here, the reason I did this is because the first referral was only for his left knee, which was about a couple of weeks after we think healing times. I mean, you got to wait about 5 to 12 weeks for those bones to actually fuse. So we were just focused on the left knee, and then about 2 months later, we were able to add the lumbar spine to the plan of care. I came in about halfway through stage 2. I wasn't there for the initial evaluations. I was there through they were part of the intervention for his lumbar spine as well as the return to work activities. So for the left knee evaluation, as I said, it was about 3 weeks after surgery. He reported pain 2 out of 10. Seated at rest, we never reported a lot of pain unless with active motion, especially at first with the swelling he had. He came in a knee brace that was locked at full extension, also wearing a TLSO, as well as an external bone stimulator. This was got 2 similar pads kind of we use for E-stem on each side of the incision, and what it does is it sends an electrical signal to promote bone growth. Usually one for a couple hours a day. So after the initial evaluation, we just asked them to make that time frame outside of our treatments. And usually done about 3 to 9 months after surgery. I think he was supposed to wear it until early March of this year. He had pretty good motion on his right leg, 0 to 150 degrees. And he also scored a 57% on the WOMAC. For those of you who aren't familiar with that, it's similar to the LEFS. It just doesn't have the more sport-specific questions, such as how you do popping, changing direction, sprinting, which I don't know if really applies to some of the patients. So the WOMAC is more towards the ADLs. It's a 24-question, higher score indicates increased disability, and it's designed to measure 3 things: pain, stiffness, and function. We also look at his mid-patellar girth. As you can see, about 4 centimeters more on the left side, which is to be expected after the patellar tendon repair. He was ambulatory at the time with a rolling walker. Weight bearing is tolerated on the left with the brace. That was like a full extension, a little difficult to walk. The range of motion instructions get about 0 to 30 degrees of active range of motion. Our goal was to increase that by 10 degrees until full range of motion was achieved. 2 months later, we got what we call stage 2, was the lumbar spine. Again, he was listing about pain 1 out of 10. He reported we found numbness in bilateral calves, but what I mean by that is more the anterior and medial portion of the lower legs, along with the L4 and L5 dermatomes, which were 2 of the levels involved in this fusion. He was still using the bone stimulator. We checked reflexes were fine, and there was no other reported radiating symptoms or numbness. And the range of motion here, something I want to point out that I'd definitely like to do over a look at again, because this was listed in the initial evaluation. I'm not sure if it would have been maybe from thoracic spine, but just looking at these 75 to 90%, there's no way that was coming from the lumbar spine after a 4-level fusion. That's definitely something off the bat I'm thinking it was more thoracic, but that's definitely something I would like to look at again. Here is strength testing. You can see everything on the right side, actually 5 out of 5. Most of his weakness was in the knee and the ankle. You can see he did fill out an ODI. Is you guys know what that is, but it's used to assess severity in which low back pain impacts function. Again, higher score indicates increased disability, and he scored a 56%. He was also under lifting restrictions of under 15 pounds, again, due to those healing times, waiting for those bones to fully fuse until we could actually progress his activity. So just overview of everything we've gone over in the ICF model. We got the health condition, impairments, also activity, his ability to perform the ADLs indicated by the woman in ODI. He was mainly reporting difficulty with walking, dressing, lifting, and personal hygiene in general. The environment that was going to be in, he's in the back lifting packages into tight spaces. What if somebody else is working? You know, he's kind of make his way around. He was a 46-year-old male, married, motivated, and strong family support from the start. Okay. So diagnosis and prognosis. This is some factors here. Some negative factors would be that he had multiple lumbar surgeries, in addition to already having a 4-level lumbar fusion. He did report he was a smoker, as well as for depression, as he filled out the PHU2. There was a study from the Spine Journal from 2016 that I looked at that the 2 most independent negative factors after a fusion were depression and any fusion involving L5 lower. So if you look at him, he fits both of those criteria, and I want to look at that. They also found, there was another study that I looked at that found that people who underwent multi-level lumbar fusion, especially 4 levels, reported increased stiffness, which obviously, but they also found that they reported considerable difficulty performing ADLs up to 2 years later. So some positive prognostic factors that I listed: he was motivated to return to work in his prior level of function. He was employed, had strong social support, and was a previously active individual. Something I wanted to put here was low fear avoidance, but we didn't do an FABQ. That would have been a subjective reporting for me. This was the person being listed from the initial evaluation when I wasn't there. Once I got there, I think, and I got to know him, he was the person I met. He was more, I think, humbled by the whole experience, the trauma he went through, and he was more just happy that he could still walk, that he knew it was going to be a process, but he was going to be able to get back to doing the things he wanted to do. But again, that's something looking back at it, is something he definitely should have done, because he did go through a pretty traumatic experience and had 2 big surgeries. Our plan of care initially was only for the left knee. So our focus was to regain full range of motion, strength, and normalize the gait pattern, especially once we got him out of that brace. Once we were at the lumbar spine, we wanted to focus on improving his function within the range of motion that he had, stability, and then progressing to perform ADLs as well as the return to work activities. We decided to do a frequency of 3 times a week for 12 weeks. The reason we wanted to do longer than 6 to 8 was because of the prognostic factors that we talked about, as well as the physical demand of the level of the job he was going to be performing. For the knee, I think he was coming twice a week, but once we were combining both clinic cares, we bumped it up to 3. We could be a little more aggressive with the treatment. Again, our goals were just to get full strength, stability, and progress to get him back to work, which was lifting 70 pounds over his head. And the expected outcome was full return to work and to his prior level of function. Before we go into intervention, any questions so far? Okay, so for the left knee, we start out with some scar mobilizations, as well as the progression of range of motion. Once you get to about 110 degrees of knee flexion, we want to get on the stationary bike. One, because I thought it was a great exercise to do some lower extremity strengthening, but it also kind of gave us a head start on promoting some core contraction for him to get that upright posture. It was a good way to start with that. In addition to, he was using an assistive device, but he was not very compliant about using it at home. And he was reporting occasionally buckling of his left knee. So we did want to focus on stair climbing, because he did have to do that at work as well as home. So we started with just step ups, whether it was having his left leg on the step, was controlling it on the way up, controlling it on the way down, for strengthening, but also for safety, especially once he started saying that his knee was buckling when he was at home. We also had some treadmill walking to the point We actually started this because he reported decreased stiffness and decreased pain at the time when he was doing it. But the more we did it, we wanted to do it for safety. We wanted to increase his gait speed, normalize his gait pattern. Our first goal was to get him to get to 1 meter per second, which is 2.2 miles per hour. This guy was about 6'4", 270. So that was, I think the first time he did it, it was 3.5. That really wasn't very challenging for him to do. And then treadmill walking is something I'll go into a little bit later. That's something we kept throughout the whole treatment. So stage 2 intervention said our initial focus was to decrease the pain and stiffness. We performed a lot of prolonged stretching of the hip and back, as well as some manual stretching and soft tissue mobilization. We really focused on progressive walking from the very start. And there was a case study that I found for a patient who underwent the same level of fusion and actually had a history of an L3, L4 laminectomy. And they found that the rehabilitation program focused on progressive walking all 3 directions, forward, side steps, and backwards, proved to be effective in relieving the post-operative pain and improving his ability to return to work. This is something we started in the gym, but as he improved, we definitely encouraged him to go out in the community. Once we felt it was safe, he wasn't using an assisted device, encouraged him to go out in the community and walk every day. We also added some stabilization and strengthening exercises, and as well as balance. There wasn't an official, I don't think it was tested in the initial evaluation, more something we saw as we went along, but more thinking safety. What if he's carrying a package, 50 pounds, somebody bumps into him, what's going to happen? So we started with more of a single leg balance approach, but again, we didn't want to stick with doing a static balance exercise for a dynamic activity. So looking back, I think I might have want to add a dynamic gait index or the best test would look at that, but that's something that he wasn't going to be doing much static balance in the first place. This one is an example of what a normal intervention day would look like. As you see, the first 3 exercises: shoulder flexion, extension, as well as abduction, sitting, and then straight leg raises in supine, side lying, and prone. All good strengthening benefits, but our primary focus on these was to kind of promote the control of his lumbar spine in neutral position. And there was a RCT that I found that was trying to come up with a protocol for people who underwent lumbar fusions, and they found that programs that focus on muscle strength, endurance, and control of the spine in neutral position will really help patients. And you look at the first 3, go along with that. We're trying to focus on motor control. More our strengthening exercises, more focused on the squat, the step ups and downs. We did add some lunges, and as I said earlier, we always kept up with the treadmill walking, also to help his muscle endurance. Okay, for about 4 weeks after initial evaluation, we did the reassessment. Found that I was the one that did this one. There was decreased active range of motion above the level of the fusion. I think if we were looking now, we might see some hypermobility above the levels of the fusion. However, you think this was right after he had spent a couple months in a TLSO, and I think it's normal for us to see some stiffness at those levels. He also scored a 50% on his ODI, which is only a 6% improvement from his initial evaluation. And I remember at the time thinking, he looks better, he feels a lot better. Why is the score not really improving? And then, but if you think back to the article that I was talking with the negative prognostic factors, people that have a 4-level lumbar fusion report considerable difficulties with ADLs up to 2 years later. So now looking back, I think it's normal to not see that big of a change after those surgeries. He wasn't reporting any numbness in the lower extremities. Let's say there was a specific intervention that we did, but I think just as he healed, kind of the irritation from those nerves went down a little bit, and we did some of the stabilization exercises. He was able to improve those symptoms. See, at this point, there was no significant gait abnormalities. He wasn't using an assistive device, but we did see that it looked like he was, I don't want to say drop foot, but it did seem like he was dragging his left foot a little bit. And it did go along with the strength testing that we did, the plantar flexion and dorsiflexion at the time. When we did it, I attributed it to the fact that a different therapist performed the initial evaluation. We have disagreed on the measurements there, the ratings, as well as I wanted to use dosing for strength. I think we might have been doing too much, doing more for endurance rather than actual strength. However, looking back, something I really would like to do is do more of a quick neuro screen. You see that? We're doing 4 weeks, nothing's changing. You know, you did have 2 spine surgeries. Look at that. That's something that came out just as I was reading this. Like, really should have looked at that. You know? And finally, we still had the lifting restrictions. And by this point, I mean, like I said, this is a pretty big guy. 15 pounds wasn't really challenging. And I think every surgeon doctor seems to have a different protocol and what they like to do. So it's kind of hard, you know. I think I would have been a little more effort in trying to talk to them, kind of get those restrictions, but get back to the doctor to get checked out, see if we were able to move forward. Because I felt like that was holding us back a little bit at the time. It was about a week later, got the note signed and said, move forward with the treatment. We wanted to move to return to work activities, more functional activities. We had to start with a functional squat. However, when he was doing it, he was reporting a little discomfort in the left knee, as well as when we were watching, we were really leaning over to the right side. So what we did more of a wall squat with the ball behind his back, and we put a mirror in front of him to kind of help him stay in midline. Once we were able to get comfortable with that, we did progress to a functional squat, putting a chair behind him, and kept the mirror in front of him, and just go down until he felt the bottom touch the chair, and come back up. We also did some box lifts, 10-pound box. You squat down, lift the box. As we got comfortable with that, progress to reaching overhead. The way our gym was set up, all the equipment was in the middle. You had to walk around. And so we did kind of simulate what you would have to do at work. So we had him squat, lift the box, walk around. We were guarding once we felt this was safe, and depending on what other patients were there at the time. And, if anybody got in his way, it was his job to get around. Make it a little more challenging for him. We did progress this, and a lot of times that was our main focus at the end. Coming, squatting down, lifting the box, reaching like you're going to put on a shelf, and then laps around the gym. For the exercise program, we just started basic strengthening exercises, the straight leg raise and some stretching for the hip and knee. Once we were able to add the lumbar spine, he got a gym membership. He was really adamant about wanting to do things. Going back to the gym was one of the things he wanted to do, so it was perfect for us. I think we were lucky in that way. So we did add some the leg curls and extensions, maybe strengthening exercises, as well as the bird dog exercise, like quadruped, making sure he was able to lift arms, start with that, and keep his pelvic in a neutral position. And then we progressed to more return to work activities later on. For the discharge criteria, he was actually discharged, I think, the week after I left the clinic. I don't have the numbers of exactly the outcome measures that he did, but the last time I worked with him, he was able to squat and lift and reach with 85 pounds in the box. He was able to stand for 4 hours without any difficulty. This wasn't, we obviously didn't test this, more subjective reporting from him at the time. And he also underwent a functional capacity evaluation, which my CI at the time was certified licensed to do. It's a 4-hour test of how hard can you push, how much can you lift, even little things like testing fine motor skills, all little things. I don't have access to that test, but that was going to be what determined if he was ready to go back to work. Finally, some limitations and do-overs. Some limitations are that I wasn't present for the initial evaluation. I do have access to the documentation, but I think there's some things I would have done differently. I think there was a few outcome measures used. I do like the ODI and WOMAC, but I would have maybe liked to use something like a photo that would have given us a way to compare how patients with similar diagnoses of the same age, they got better, they got to this level in this number of visits or something to compare it to, I think would have been helpful. There wasn't access, I didn't have access to a surgical report. I don't think this would have had a huge effect on our intervention strategy. However, I think we're curious to know what approach they took for fusion and laminectomy. And finally, not having access to actually the functional capacity evaluation. It's more subjective. He was saying he felt ready to go back to work. Look, he was 85 pounds overhead was a lot. We're showing him because none of us could do it. Pretty strong guy. And then do-overs, as I said, I would have really done to a neuro screen once we saw that. Not a lot of progress in the reevaluation. I would have liked to perform an FADQ to get an idea of the severe avoidance or similar to something like a STAR back tool assessment. I think we're given like a screening tool to give us the risk level, some of the interventions. I would really like to reassess the range of motion, and as well as the last one being more aggressive in treatment. The reason I put this one is because when I was doing research, I found one article that was talking about how most people after a lumbar fusion, after they finish their PT program, they're still considered functionally weak. And if you're 70 years old, maybe it doesn't stand out as much, but what happens when you're 46 and have to go back to a physically demanding job? So what they did is a rehabilitation program for 8 weeks focused on overhead press and deadlifts. And they put everyone to a different category, how much they could do from light to very heavy. Light group considered being able to lift something under 20 pounds 8 times a day. So the very heavy group was able to lift over 100 pounds 8 times a day. After 8 weeks, they saw most of the patients they used were over 65, which would be a limitation itself, but they found that most of them started in the light group and finished up in the medium group, which was between 50 and 75 pounds overhead. So that's the reason I put this with a question mark, maybe something to think of, but it's not something I actually added to my interventions. Here are my references. And, okay, let's do it.
So, is there any way you can go back to the animal testing? So for his plan of function and motion flexion, I might have missed it, but clarification. Were there, did you go after any interventions that were specifically targeted for the?
Yes. Pretty basic, we were doing even just heel raises or actually toe raises we had to do. Aside from that, we did start with some Tendon when we were doing more of the supine strengthening. But like I said, I think it was more of a dosage problem in the beginning. We were focusing on it, but maybe not enough. And I think that's what I attributed at the time. More of a dosing issue.
What you were attributing to trying to do a nerve screen on it?
Just not seeing any progress 4 weeks after. So strength, or was there something we were missing?
Yeah, you've said it 2 or 3 times now. I'm glad you did, because I think anytime you've got back surgery, low back, whatever, if drop foot enters your mind, just test it. You know, because you don't want to miss that. Not saying that that's what this was, but just it'll take you so little time to test that.
I was very biased and focused on ortho. I was like, oh, it's got to be a strength issue.
Yeah.
You know, to think back, like even reading, I was like, oh, that's, come on.
And then the other thing, did you ask him, around his depression, was he seeking any treatment for that? No. Another nice thing that you can do sometimes too is if they're telling you it's there, then usually they're very good with you having a conversation around it. And just asking them sometimes, do you think that's having an effect on what's going on right now? As far as your back surgery, your knee surgery, or getting back to work, do you think that's affecting? Sometimes that can be a nice clue too to say, okay, maybe I should bring in another outcome measure around that, or consider other services if needed. So.
I think also, not that it'd be normal, but you know, it's a young guy, active guy on the web. It's a lot of trauma to go through those big surgeries.
Yeah.
But like I said, that was the very beginning, and I still think I should have checked it, but at least that's almost not the guy I met. You know, once I was working with him, he was just like, yeah, let's do it. Yeah. Like he came ready to work every day. He was happy to be there.
Question for you.
Okay.
No, really, it will be.
Okay.
All right. So I just like, you know, the multi-accident type stuff, right? So we're looking at the gentleman who had some patellar tendon repair, and then you talked about having to wait until starting the lumbar repair rehab. Yes. Was that based on your judgment, or was that based on the physician saying you have to wait a certain amount of time?
The first initial referral was left knee. We knew, like, we had the report saying what happened. Okay. He told us the first day, but said, you know, they wanted him in the brace, waiting until those bones fused.
Okay, and so the case study and the randomized control trial where you actually found some programs specific for the fusion, were the post-op guidelines associated with dates associated with those as well? That you remember?
Not those. There was some articles that I didn't use for this that I looked at, but they were all very acute care, like what to do. This walking helped within the first week. I was like, that's interesting, but I saw him. By the time I came in, this was months later. So I don't know if it directly applied for those, but no, the ones I think they took anybody that had it in the last 5 years. There wasn't any significant time frame in there.
Did you find it interesting to say that, okay, I can just work on your knee?
What do you mean?
Well, I mean, you had the plan of care specifically for a knee, and here's a gentleman with TLSL. You have to kind of ignore.
Yeah, ignore as much as you can. A lot of the exercises gonna blow over. Like I said, doing the bike, we're doing straight leg raising, then like all the supine exercises. But, you can't really ignore your core. Yeah.
Right. So,
This will sound like a ridiculous question, but I'll ask it anyway and see where you go with it. You mentioned that you did some stretching exercises to his hip and his knee. Why did you do that? And can you talk about that a little bit?
Stretching exercises. Well, I think he came in with a lot of tightness. He kept saying he felt stiff. There was a lot of pain, and we were doing just more of the manual. You can tell. Not sure that we thought it was going to improve his motion, but I think at times we had to do it to decrease his symptoms and tightness, so we could move on to the treatment or more, I guess, functional activities forward.
So kind of the direction I'm going with my question is, were you actually targeting what was limiting his range of motion and function? In other words, for example, did you consider doing joint mobilization as opposed to stretching? Why would you choose one versus the other?
For the knee, yes, not for the spine. That's what you mean, I think.
I just meant in general.
Okay.
One thing I didn't hear was test, treat, retest. So I'm just wondering if you use that model at all as you were treating the patient. For example, is knee range of motion is some limitation, you offer a stretch, you remeasure the knee range of motion. Did you find an effect? If not, well, maybe it's not a stretching issue, maybe it's a joint mobilization issue. Did you work through that process at all?
Honestly, no. I think that's a good idea. Something we should have done. By the time I worked with him, I think his knee active range of motion was about 0 to 140 degrees, which for him, because we still consider a little hypomobile, because the other side was 150, but it wasn't going to affect his functional activities. And by the time I got there, I think we were more focusing on end stage, like lumbar plan of care, and getting back to more functional activities. But I think that's a good point. I should have used more if I was there for that part.